Hello, good evening. Yes, it's both is visible and audible. Thank you very much, Doctor.
Oh, thank you. So let's begin.
Okay.
So welcome everyone. In this session, we are going to talk about MRCOG Part 2. Hope everyone in this webinar have joined. Yes?
Yes.
Okay. So before I begin, this is the MRCOG Part 2. We will be discussing some questions regarding MRCOG Part 2 and some tips and tricks also, how to tackle the questions. And before I begin, may I know everyone, there's all the participants are preparing for the part 2. Can you just let me in the chat box who is going to give the part 2 in the November? Anyone? Okay. So Jazwa is in January. Part 2. Anyone else in Jan? Okay. Sarah, Sima, all in Jan. Okay. That's very good. Okay. Hope you guys are preparing well. Let's start the discussion. My name is Dr. Rana Mandal. Okay. And we'll be discussing some important things. Before I begin, I just introduce myself. I cleared this MRCG part examination and got admitted as a member in 2021. So typically what happens is the part 1 is the easiest step, you guys. And part 2 is a little bit of difficult and part 3 is also more or less similar exam. Now, you can see in my bio is here, but what isn't is there is that I am also an MRCOG. MRCOG learns courses of MRCOG, and also I am an examiner of European Board of Obstetrics and College, Obstetrics and Gynecology College, this EFOG Part 1 exam. So if you guys are going to give European Board of College examination, that is also be helpful in this class also. So what is the you guys aim is what? This is the what is this diagram? Is that is the RCOG college. This is the new building of RCOG. It's very close to the old building. And your mission and vision is to enter in this college. So everyone, is it right? So I want this is to be interactive session. You can say yes, or you can put in chat box yes. That will be very helpful, so I can know if you are guys with me. Yes, that's very good. So this is the college where you will get admitted after passing all the 3 parts, and this is the hall where we will get your admission ceremony as a member. This is me. I got admitted I passed part 3 in the November 21 and got admitted as a member in this hall in the December 22. So it was a very good, proud moment for me, and most of you will come to begin. Success is eventual. You guys will get everyone who are guys are preparing for this part 2 examination. Everyone will go through it, but it's just a matter of time. Part 2 isn't a difficult exam, but it's the covering the whole syllabus is very difficult. So here comes my teaching experience and the opportunities. What we guys do is give you the concise material. So if you guys have much time, so if you guys can read all the guidelines, all the talk articles, all the strategy materials, then you guys definitely answer every question. But the difficult part is that we don't have enough time to accumulate all the material, all the knowledge, and to most importantly revise it and remembering everything. That is the most difficult part we face. And this part 2 examination is all about the knowledge. Showing your knowledge is the most important thing in the part 2 examination. So this is our part 2 syllabus. There are 18 modules, and almost every module, the questions come in the form of SBS, single based answer, or as a multiple, or as an EMQ, extended matching questions. Now to remember, the extended matching questions come from typically for few of these modules, especially comes from the surgical or post-operative area, and of course 1 or 2 will come from antenatal and maternal medicine, and of course at least 1 or 2 will definitely come from the management of labor and delivery and gynecological problem and early pregnancy module. These are the modules where you have to focus for the extended matching questions. Whereas the SPA can come from any one area, and SPA will have a more depth of knowledge. Whereas extended matching question isn't how you manage and how you organize yourself and how much you know and how much clear your concept is, that is tested by the EMQ. Whereas SPA tests your depth of the knowledge. If you know it, you will definitely can answer it. If you don't know it, probably you won't be able to make it. Now, in this session, we'll be discussing 20 SBA questions. Out of that, all are the recall questions. 10 questions have been more come into past, and the later 10 questions we'll be discussing that have come in recent years. Okay, so what is this? Now, I wanted to guys focus on two things, that these, although the questions volumes are equal, that is the 50 questions will be from the ASP and 50 from EMQ, but the marks you will get, that is not equal. 60% marks carries in the EMQ question, and these are more technical questions, and you have to have clear concept and clear organization to answer this question. And whereas the part 2 will assess your the depth of knowledge, and it covers not only the guidelines, it will cover, SPA will cover also the talk articles, recent papers, scientific impact papers, and also some journals and some strategy materials are need to be covered to complete all the part 2 MRCOG SBA chapter. Whereas in EMQs are simple. EMQs will come for definitely some most often come from the guidelines, especially from the NICE guidelines. As a paper setter, we have been instructed to give from the EMQs from certain topics, because from like NICE guideline, ectopic pregnancy and early pregnancy model, we have to give an EMQ because the marks are distributed like that way. So it's very easy for EMQ, setting up EMQ, but answering the EMQ is not that much easy. So, but in this today's session, we'll be discussing more towards SBA. We'll later have an EMQ session as well. Okay, so let's begin. But before I begin, I just wanted you guys to answer the questions, and I want everyone to participate in this. Don't matter it is wrong or right. Some questions will be very easy for you guys. Some questions won't be easy, especially if you guys are preparing for a long time. Probably if you're 2 or 3 months or more than that, then the questions will be very much easy. Whereas some questions may be not very much easy. But what I want from you guys is to answer every question and put the options in the chat box so we will be know. Okay, so are you guys ready? Just type in box yes or no. Okay, good. Okay, very good. So let's begin. Don't give more than 60 seconds in a SBA question. Okay, so everyone is right. Okay, so most of you are right. Dr. Yum, can you please guess why you have chosen the B option? Because it's kind of very clear questions. Okay, let's see begin. But we can know. Of course, it is 20%. And of course, you are also right. In the second year, 90%. So Vani, can you tell me what will be in the third year? Can you type in chat box? You have said rightly in the second year that will be in the 90%, but what will be in the third year?
$90 only, sir, because 10% are unexplained infertility.
So what matters? That matter. By the way, in the after 3 years of even unexplained infertility, it has shown that around 95% get conceived. In third year, it's not 90. You can see that in the ASRM guideline. It's not in the NICE guideline, but it's okay. You have done very good still. Okay, but can you tell me, for whom this is 80%? Is it for everyone?
No, sir, it's not for everyone. It's for those patients who don't have any underlying medical disorders, means, and they are having regular unprotected sexual intercourse.
No, dear. I am afraid not that only. You have to look at the age. Because this question has been old question and it has given 36-year-old. Would have been the answer would be same if this question had reframed like that. 42-year-old came with her husband. What is the chances of conception in the first year? Yes, that's fine to know that it's less than 40 years. Yes. What would it be if it is more than 40 years? Anyone has
Then we
studied
will investigate.
strategy? Yes, yes.
We will investigate earlier, sir. Then 6 months, I think.
No, I am just asking you what are the chances of spontaneous conception for more than 40 years old, between 40 to 45, considering everything is normal. Her ovulation, tubal factor, husband semen parameters, everything is normal.
%, sir.
No, you're close actually. Well guess. Yeah, 50 is correct. It is correct. Did you get it or know it?
Yes, sir. It is. We have to concentrate on the age of the patient, and then
Yes.
how long is the infertility?
Yeah.
How long is the period they are
So
asking to conceive?
yes, that's a very important thing. Yeah. So whenever you're don't go with the old answer, of course it is an old question, but look at the other parameters as well. Okay. So this is what is given in the guideline. 80% conception rate if only woman's age is less than 40 years, and all other parameters are almost normal. Whereas in the second year, it is 90%. And these data are kind of old data. Let me tell you, because I am a reproductive medicine specialist, these data are from the around 2013. A study in a first trial that has been published. From that data, this has been given, but NICE guidelines haven't updated it till now. But still, it is considered in the UK. And the second year cumulative pregnancy is 90%. And of course, you're right. And in the third year, it's considering everything is normal, unexplained infertility. If the patient wants an expected management, you can tell her that there is a chances of conception also. Now coming to the next question, it's a very easy one. Come on, everyone, quick. Oh, so all of you are right. So I didn't need to explain this thing. Sarah is also right. 1 in 1 lakh is correct. But usually the confusion begins in the option D and E. As you guys have made all the, everyone has made the right answer except for Aisha. Please be careful. It is less than 1 in 1 lakh. That is the right answer. And usually we get confusion in these things. As I told you, it has to be less than 1 in 10,000. It has to be. It's not if it is 1 in 10,000. What it be considered? It would be considered as a rare, not and very rare. To make it clear, usually in these positions, candidates get confused. Okay, everyone of you know these things, and usually it is described in this way. Very common is 1 in 10, whereas common is 10 to 100, and uncommon is 100 to 1000, and rare is 1000 to 10,000, and when it is less than 10,000, it is very rare. Okay. Risk description is not required for part 2 preparation. as if you don't guys need to explain to the patient. But when it comes to part 3 preparation, you guys need to explain. If a some disease is very common, then you guys need to explain not in the term in a layman. That is a, if it is very common, you don't say 1 in 10, it will say it's a person in family can be affected like that way. So when you guys preparing for part 2, it's better to know this layman term also, like in given in the description. So it will be easier for you guys for part 3 preparation as well. Okay. So ready for the next question? You guys are doing amazing actually. You guys are doing every question is right, most of you. Okay. Let's see. Mm-hmm. Mm-hmm. Okay. So questions are coming, I think, difficult, or now I am getting a mixed response. Not an unanimous response now I am getting. Okay. So, okay. That's very good. Very good. Most of you have done rightly said. It is a 25%. Okay. Why it is who has a since 40%? Can you tell me in which condition it will be considered as a 40%? Remember this thing. One thing I am like to say here. Yes, 43 in hysterectomy. Yeah. Okay. One thing I need to tell you guys that complex endometrial hyperplasia, simple endometrial hyperplasia is this is the question. It's an old question, so they have used this term. But now you guys may not have this term as complex endometrial hyperplasia. You guys will have endometrial hyperplasia with atypia or without atypia in this term. Complex, simple endometrial hyperplasia and complex endometrial hyperplasia. These terms have been outdated by WHO in 2016. Okay, let's see this thing. You guys have to remember the thing I wanted to highlight here is that the endometrial risk of cancer is less than 5% over the 20 years if it is without any hyperplasia, without any atypia. That is a simple hyperplasia without any atypia. And when it comes to the atypia, it's around 20. Actually, it is at 28%, but in this question it is given 25%. That's also right. What if the simple hyperplasia without atypia is 5%? Simple hyperplasia with atypia, how much? Anyone? Can you put in the chat box? Come on, simple hyperplasia without atypia is 5%. What would be the simple hyperplasia with atypia? No, dear. Simple hyperplasia with atypia, I'm asking, not complex hyperplasia with atypia. No, don't guess. Mm-hmm. 8% is kind of very close. Yeah, it's actually right, 8%. Yeah, 13 is not the correct thing. Remember this way, if it is a old classification, in old classification, they have simple and complex with atypia and without atypia. So if it is a simple endometrial hyperplasia without atypia, it is 5%, less than 5%. And it is simple hyperplasia with atypia, then it is 12%. Okay. Whereas complex hyperplasia without atypia, it's 8%. Whereas complex hyperplasia with atypia, it's 28%. We can say 25%. Is it clear? Or do I repeat?
So please
Hello?
repeat.
Okay. So dear, can you just put in the chat box what I am asking? Simple hyperplasia without atypia, how much? When it is given in the slide, endometrial hyperplasia without atypia. That is yes. No, dear, it's not 8%, it is 5%. Yes, less than 5%. Simple hyperplasia without atypia is less than 5%. What is simple hyperplasia with atypia? How much?
It's 12%.
Yes, yeah, 12%, correct. What is only complex hyperplasia without atypia?
8%.
Yes, it is 8%, correct. Okay, and complex hyperplasia with atypia? Yes, 28%, very good. So which treatment is better? What is the baseline treatment for endometrial hyperplasia in a perimenopausal woman or premenopausal woman? Yes, LNG IVs, that is the first line management. Yes. Yes. Can you guys answer what is the chances of regression with LNG over the 5 years? What is the percentage of regression over the 5 years considering BMI is less than 35? Yes, 90%. Excellent, excellent. You guys are really preparing well then. No, dear, it's not 60 to 80%. 60 to 80% is for progesterone therapy, not LNG IVs. Remember the thing that the LNG IVs has higher regression rate compared to the progesterone therapy, and progesterone therapy has more regression rate compared to the observation. If you can see, guys, see this the last line I have put it on. If the BMI is less than 35, patient is non-obese. If you are doing only observation without any expected management, the chances of regression is only 40 to 50%. Whereas with progesterone therapy, chances of regression goes up to 8%. And if you are using LNG, chances of regression goes up to 90%, beyond 90% over the 5 years period. So is it clear to everyone?
Yes, sir.
Okay, very good. So going to the next question. Sorry. I am waiting for the answer. It's a old question. Please type in the chat box. Yes. You guys are really preparing well, I guess. Yes, the correct answer is 4.4%. Exactly. So the basic idea is that you guys need to read this guideline of antepartum hemorrhage very thoroughly to answer this question. And usually an EMQ comes from antepartum hemorrhage from the management point of view, and M1 or 2 SPA may come from the antepartum hemorrhage, but definitely one EMQ will be from the antepartum hemorrhage. So let's begin. This is from the NICE guideline. 4.4% incident of the recurrent abortion rate. For this is a risk the aberration in the future pregnancy 4.4%. Okay. Just read this guideline. Those who couldn't answer it correctly, it's not 25%. Read it correctly. But you are right in case if you had more than 2 or 3 aberration before, then it is 25% when the 2 previous pregnancies get complicated by aberration, then it is 25%. Increases from 4.4% to directly to the 25%. Okay. Next time, these questions may be reframed in this way. So the idea is to have read the guideline thoroughly, not to just read the overall and have an idea. So move on to the next question. Okay. So let's see. Okay, fine. So everyone you have guys made it right. So just to give an idea, okay, to complete this session, remember what is written in the below is from the guideline. 50% have midline, 50% of them will have addition. Those who have midline laparotomy, whereas in the transverse incision or Joel Gwen incision, it's around 23%. And these are per part taken from the TOG article. It is around 52% they have said, and for those who have transverse laparotomy incision, it's around 20%. So in the recent questions, you may not get the 23% option. You may get 20% option. Choose that one. And for those who had no previous addition till previous surgery, still you may find around 0.6% of cases there may be addition. And those who had laparoscopic surgery, around 6% of them will have addition. This hasn't come in question still yet, but it may come. Can you guys tell me after how many failed attempts one should consider of the open Hassan technique or open method in the laparoscopic surgery?
Hello, dear students. Please wait for mentor. There's some technical glitch. He will join back.
Hello, am I audible now? Sorry for my connection got disturbed, so I will just start sharing the screen again. Is it visible? Okay, so where was I? Oh, I was discussing what are the percentages. Yeah. So so can you have put in the chart box what are the chances of having addition if there is a laparoscopic surgery previous? Because nowadays laparoscopics is more. Come on, it's on the slide. Yeah, very good. So let me know what are the rate of the complications after failed attempt. You all of guys know that after two failed attempts, one should consider for the other entry side, that is a Hassan technique or a Palmer points entry. Now, what in the percentage of the vascular injury if there is more than 3 attempts? It is given in the talk article. Can you guys guess? Or anyone, if you know, it may come as a potential name question. Anyone? No, dear, it is not 20%. In the RCOG guideline, they have clearly mentioned that after 3 failed attempts, one should consider for the doing other open surgery as well. After 2 failed attempts from the midline, you should consider from entry from the other side, that is open Hassan technique or Palmer's point entry or Li Huang point entry. And after 3 attempts, you should consider for open surgery. Now, after 3 attempts, in chances of vascular injury, it's much more. No, the incidence is very high. It's around 64% after 3 NT. So you guys haven't read the talk article, I think. So what will be the pressure if you are doing a laparoscopic surgery? And what pressure you will confirm that the varus needle is inside peritoneum? No, dear, I am asking at what pressure you will be confirmed that the varus needle is inside peritoneum, not the primary entry pressure I am asking, Sabina. Excellent. Saba is right. It's 8 mg. Excellent. It's a dear vascular injury talk article. It's not 15%, it's 8 mg. Okay. And what should be the peritoneal pressure in the primary entry? Everyone? Yes, 20 to 25. And what should be the for the secondary port entry? Isha, Arjumat, why it's 15? Yes, same. Yes, Saba is correct. Remember, all the secondary ports and primary ports should be entered according to the guideline. It's 20 to 25. And when all the ports you have entered, then the operating pressure should be around 12 to 15 or 10 to 15. Yes, correct. So these are a few more things. Remember that the major vascular injuries occurs in a 1 in 200 laparoscopic surgeries. This has been asked in previous questions that has come in past in 2021. In my exam, this question has been come, what is the incidence of vascular injury during laparoscopic surgery? It is 1 in 200. And these other things you may not remember. The conversion rate is from the laparoscopy to the laparotomy after the vascular injury, 1 in 380. That is also from the talk article. This is a very important talk article. Those who haven't read it, please go through it. Of course, it's children, it's different. Don't worry, you won't be asked for children. If for your kind knowledge, the children for entry pressure is around it's around 15 to 18. It should not be go more than 18, and the operating pressure is around 10 to 12. Okay, this is for the adolescent and teenage adolescent girls, not for the children below 5 years. Okay. So this is the entry point. All of you guys know there is the most common entry point is the umbilicus. From the you guys need to understand that the base of the umbilicus you should choose not from the lower side or apex of the umbilicus. It's always should be from the base of umbilicus. Now, what type of incision we will get in the base of umbilicus? It is vertical or transverse. Come on, these are all given in the guideline. I just wanted to know if you guys have read the each. Okay, it's transverse. Sabine, you need to read the guideline again. Yes, it is vertical. I know many of you guys practice transverse incision, but in the examination you need to choose the option which is given in the guideline. Many of us do give the transverse incision during creation of pneumoperitoneum, but the guideline has given its vertical incision to give. And these are all the entry points. Now, if after 2 failed attempt, remember to choose for other entry point. You can choose either open Hassan technique or through the Palmer's point entry. Remember 2 things, how the questions are framed. They will give some comorbidities, and according to that, you need to choose answer. If they give the patient has a multiple major surgeries, would you choose the Palmer point or the open Hassan technique? Which one?
Palmer's point.
Yes, exactly. And when would you not choose? Okay, I am coming to it. What is Palmer point? Okay. So you can see that the Palmer point over here is the Palmer point. That is the when if you draw a line from the mid-costal cartilage after the lines intercostal below 3 cm below and medial to the line costal cartilage is the Palmer's point. Okay, when you not choose the Palmer's point, what are the condition? Yes, if that's a history of splenectomy or splenomegaly. So the questions may come like this way. If they have give the option, the patient has a history of splenomegaly or storage disease, in the cases where the spleen get enlarged or history of splenectomy previously, then you should choose the open Hassan technique. And if they give history of multiple lower abdominal surgeries, then you should choose after 2 failed attempt, you should choose of the Palmer's point entry. No, dear, it's not after 3 failed attempt. After 3 failed attempt, you should think of doing laparotomy instead of laparoscopy. After 2 failed attempt, you should choose for the alternative entry point, that is a Palmer point or open Hassan technique or Li Huang's point. When you choose for the Li Huang's point, Can you guys please guess when, in cases where you will choose Lu-Huang's point? Lu-Huang's point, if you draw a line between the Ziphy's sternum to the umbilicus, midway point is the Lu-Huang's point. Large mass, that's a vague answer. I want to know the specific answer. In which condition, if given in the question, you will choose the Lu-Huang's entry point? It has come in the European Board of Examination. I haven't seen yet in the MRCOG, but it has come in the European Board Examination. Yes, fibroids in the what size of fibroid? Exactly. Large fibroids, if it is palpable around 20 weeks or more. 20 weeks means, remember, around in the umbilicus region. If it is the mass is so huge that it's around 20 weeks and it reaching up to the umbilicus, then you can choose for the Lu-Huang's point. Okay, and another major indication is for doing surgery in the second trimester of the pregnancy. Like in a dermocystectomy in UK, many of centers now going through laparoscopy in the second trimester of pregnancy, and it has to be done through a Lu-Huang's point because uterus will be enlarged in those cases. Okay. In the future, these questions may be reframed like this way. Not in the failed Palmer's point, you will be choosing the Lu-Huang's entry. No. Is it clear, Vani? Failed attempt through Palmer's point does not give you right to choose for the Lu-Huang's entry point. Okay, so lots of discussion. Now going to the next question. Okay, it was a simple question. I think everyone is right. Or you guys are maybe preparing so good. Okay. So the stillbirth rate in the UK is around 1 in 200 babies born dead, and whereas the chances of sudden infant death is 1 in 10,000. It hasn't come yet, and I don't know it will come or not, but I have just put in, it may come in that way. I have put in. Remember in UK, it is around, this has been come in multiple times in the past, the rate of stillbirth 1 in 200. Can you guys tell me what else in 1 in 200? If there are many things in 1 in 200 is there. No, I don't mean point. What are the incidences 1 in 200 else is there? That has come as questions in past. Yeah, very good. Ruptured skirt uterus in labor, very good. Okay, nice. Let's go into the next question. Yes, of course, female sterilization also there. Yeah. Excellent. So most of you know the answer. If it is less than 15 weeks, it's around 15%. And if it is around 15 to 20 weeks, it's 25%. And if it is near term or term, it is around 70%. I have put this slide. This is a very important slide for you guys for examination purpose. I have purposefully put this slide because some neonatal features you need to consider as which type of infection is going to become. If it is a baby is having visual impairment or sensory neuron hearing loss, you should consider for a CMV infection more commonly. Okay, and if it is having a birth defect, especially severe birth defect less than 16 weeks of gestation, then you should consider for rubella infection. Okay, and whereas syphilis, you will get certain specific features for syphilis, and especially the skin condition they will be saying, then you should consider for a syphilis. And if the term microcephaly has been used and patient has a history of travel from an endemic region, please consider for Zika virus infection. Okay. This slide is not that much. Okay, let's go on to move into the next question. Please put the answer in the chat box. Oh, Sawa, no. Okay. Those who are answering the question, please look at the gestational age as well when answering the question. Okay, there are lots of mixed answers in this question. I want everyone to participate. It doesn't matter you are right or wrong here. Just participate in the answering the question. So I guess this was a tricky question. But remember, this question has come at least 3 times. I know. It is what I know from the past. This question has come from at least 3 times, and it may come in the future as well. These all are the recall questions what I am doing. So many of you have chosen 1%. Okay, let's see. Those who have done the correct answer, congratulations to them, because I think it was a tricky question. If you have read the guideline properly, you would have find the answer. It's from the guideline itself. And when you are answering the question, please look at the gestational age very carefully. Whenever you are answering an SBA question, please look at all the parameters in the question's age, gestational age, in the pregnancy questions very carefully before answering the question. Okay, let's see what is given in the guideline. Jump into the second bullet point. Okay, read from this guideline. If the maternal infection occurs around 1 to 4 weeks before delivery, it's up to 50% of babies are infected, and 23% will develop clinical varicella. It's near to the 25%, right? Why you guys are obsessed with congenital at this stage 1%? But this is given in the guideline. In which time most of infection will occur at the term, right? still some of you are not satisfied, but please go through it and read the guideline. I have put the bullet point, that is a summary point, also in the front. If the maternal infection occurs in the last 4 weeks of pregnancy, there is a significant risk of varicella infection in the newborn. And this significant risk is up to 50% babies get infected and 23% will develop clinical varicella. Okay. Planned delivery should be normally avoided at least for 7 days after the onset of maternal rash. That is to allow the path of the transfer of antibody from mother to child and provide a continuing the pregnancy does not pose any additional risk to the mother and baby. So whenever reading the guideline, please don't just read the bullet points or the summary points. Also try to read the inside materials as well. Of course, we are there to help you in that regard. If you guys not able to read all the guidelines, we do provide the summary and the important points. And also remember, if the severe chickenpox is most likely to occur if the infant is born within the 7th day of onset of mother rash, or if the mother developed the rash within the 7 days of delivery. This 7 days from the delivery point, either way, is very important. And for the baby is born to the mother who had chickenpox within 7 days before or 7 days after the delivery, it is very, very important that the neonate receives the prophylaxis as soon as possible with varicella zoster immunoglobulin with or without acyclovir. There is no need to test in these circumstances. So in these questions, I have given you what is the percentage. The next time the question may ask in that way, in which duration there is the highest risk, that is the 7 days before and after the delivery. And if this time infection has occurred, you have to provide a varicella zoster immunoglobulin to the neonate as well. Is it clear to everyone? Yes, I know that there is option is 22% is also there, but in this question and also in the strategy it is given in the 25%. It is very close, I know, but sorry, in that case, most of the answer is given is 25%. This is a very important slide. Try to remember the incubation period, in the which period in the most the infectious time. For a chickenpox, 4 days after onset of symptoms. For the roseola, from the beginning of the onset of the fever, 7 to 10 days from the onset of the fever and when the rash gets off. And for the measles, from the 5 days before the rash appears and the 7 days after the rash has gone. And for erythema infectiosum, 7 days before the rash appears and to the rash appearing time. And for hand, foot, mouth disease, from the onset of the sores in mouth till the fever has gone. Okay. So these are the infection period. You need to be careful these terms whenever you're reading the questions in the SBA. I think all of you guys has read this guideline and this chart, read this thing. I am not going to discuss all these things here. And this is given in the, if the newborn risk, this is from the pediatric Royal College of Pediatrics division. This guideline is also sometimes questions come in the postnatal period, then you need to follow this chart as well. Okay, coming to the next question. I thought this is a simple question. Till there is a mixed of answers. Is the term non-rotational confusing? Okay, fine. Let's go to the answer directly. It is 6%. Of course, those who have current pointing 6.7, it's given in the guideline. That's true. Let's see. If you are going to the patient information leaflet, you guys, this is taken from the 6 out of 100 births for the primary gravida and 2 out of the women who had been given previously vaginal birth, risk of third and fourth degree perennial tears are there. Term non-rotational is equivalent to the normal one. Please remember, non-rotational does not pose any additional risk. Okay, so those who have been confused, don't be confused with the term non-rotational. If it is given a forceps delivery, it's more. It's around 4 to 12%, and it is a vacuum. With forceps delivery, third degree and fourth degree tear can happen up to 8 to 12, and with vacuum, it is 4 to 8%. And the chances of vaginal laceration with vacuum is 10%, while in the forceps it is 20%. Is it clear, guys? Thank you. Come on, move on. Fast, everyone. From which guideline this answer is there? In which guideline the answer is there? Can you tell me? Okay, fine. Most of you guys have been correct regarding this. Yes, the labor guideline they have clearly mentioned in the last of the annexed part. The individual risk of physiological management and the active management they have individually given in the labor guideline, not the PPH guideline. We are coming to the more recent recalls. Fantastic. Can you guys put which type of estrogen replacement therapy will you choose for this patient? Yeah, it's local. Very good. Local or vaginal. Yes. Yes. Excellent. So all of you guys has given correct answer to this question. So I guess you guys have read the female sexual dysfunction talk article. Coming to the next question. Yeah. Let's see. This is a very recent question from the exam. Kind of mixed answer. Easiest one for the patient. So it's kind of mix of answer. Can anyone tell me why those who have choose corpus suspension, why you guys have choose the corpus suspension? You can unmute yourself and tell me.
So because it will take care of stress urinary incontinence and also will cause least interference in the marital relationship.
Read the question point again. What prolapse treatment would you prefer for this patient to improve her sexual dissatisfaction? They have specifically asked only to what option you will choose to improve her sexual satisfaction. That's why I ask you guys to answer it. Why you have choose corpus suspension? Remember, whenever choosing the question, answering the question, be careful with the age, what comorbidities patient is having, and when you're answering choosing the option, please try to look at again what exactly they have asked for. No, dear, ring pressure won't disturb her sexual activity at all. SPs are to ascertain your knowledge of depth from the every chapter in the guidelines and talk articles. So I have chosen like this way, and there is more recent questions that has come in the exam. Yes, ring pressure will help in SUI as well. Very good. Those who have chosen as a chlamydial infection, but those who haven't chosen is a kind of simple question. But yes, those who have chosen as a cervical smear, please look at the age of her. At the 21 years, usually in UK don't get cervical smear screening. Yeah. If this lady had the age of the lady was 52 years, what would be the after? Can you please type in the chat box if the age is 50 years? Yes, exactly. Endometrial sampling will be the first option you need to choose if the age was 50 or above. Yeah. Not you don't go to directly for hysteroscopic biopsy. You need to choose to do endometrial sampling. Yes. So this was from the talk article. The investigations you need to perform whenever the young lady is coming, do a physical examination, and you need to do a microbiome swab test. And if positive, you need to refer her to the genitourinary medicine specialist, and also contact her tracing, partner tracing as well. If only do cervical screening, it is overdue. If the age is and his age is more than 25. If the age is less than 25 and cervical screening has been not in due, then don't choose a cervical screening at all. Only thing you need to choose for cervical screening, only if there is a suspicious, there is a growth or anything abnormal, clinically abnormal cervix, then only you will go to choose for the colposcopy examination or screening. These are the few important conditions for the postcoital bleeding causes, and all of you guys know it, I think. And remember, if these two situations arise, you need to refer them within the 2 weeks pathway, that is emerge fast track pathway you need to put if the patient symptoms of cervical cancer or abnormal on a physical examination, you have abnormal cervix or vagina, then you need to fast track this patient to the 2-week pathway. So this is a new regimen for the PID in the UK that's been put in here. The thing you need to understand here is not in the chart box that is given in the below the chart box. In the UK, they used liberally this fluoxetine group of drug, ofloxacin and moxifloxacin, and it is now very highly expensive major concern in the UK public health. So whenever choosing the option, don't choose this fluoxetine group of question. And in the past, they have asked in which resistance. In the most commonly resistance group in this STI group of patients are having. It is a fluoxetine group of patients. And it's one question is given in strategy also. So try to remember these things, and that the fluoxetine and moxifloxacin in UK in the young age patients, those who are having sexually transmitted infection, should not be chosen. So we are moving to the next question. Come on, all of you, we have few more questions to left. So only one answer so far. Can you guys put your name rather than putting iPhone? So again, I'm having a mixture of opinion now. So you guys are choosing trachelectomy. Many of you have choose trachelectomy. Okay, nice. Mhm. Mhm. Okay, let's see. Dr. Seema, how can pelvic defect notification only doing pelvic dissection will help them? Okay, let's see. Yes. Those who have okay, so in her pregnancy, those who have choose trachelectomy, you guys will do trachelectomy in this pregnancy. Okay. Let's see what this guideline or talk article has said. Those who have done this correctly, congratulations to them, because it is kind of new and kind of tricky. So please, those who haven't read this talk article or read the FIGO guideline, please go through this article and go through this. And if you don't have the time, go through this chart. Okay. Remember, sometimes they may give directly the staging of the cancer patient, or sometimes they give only the description of the staging. In this case, they have given directly stage 1B, 2, and the age is just 23 weeks, which is more than 22 weeks. They have chosen, so you need to choose for neoadjuvant chemotherapy or delayed therapy. And only this RPLNT not only for, okay. So remember, when you are choosing the answer, it is very important to look at the clinical condition and the gestational age of the pregnancy. If in sometimes most of the cases in the questions they don't directly give you the staging, so you need to score them accordingly. And if the staging is directly given, then you need to see the gestational age. So first you need to see the clinical features and the in radiological investigation to the score, and then you score, then you see the gestational age, then you choose the option. If the score is 1A2 or 1B1 and it is less than 22 weeks, then you can do pelvic lymphadenectomy. Then after post-treatment, you need to consider termination of pregnancy as well. And whenever it is more than 22 weeks, you can give neoadjuvant chemotherapy. Can you guys guess after which age, gestational age, chemotherapy can be liberally given in the cervical cancer patients?
After the first trimester, doctor? After the first
Have you read the
trimester, we can...
guideline, read the FIGO guideline, or read this talk article? I want others' opinion also.
All right. No, I should to update it. No.
And if it is a stage B2, it's kind of also then less than 22 weeks. You do the pelvic lymphadenectomy and then consider termination of pregnancy also. And if it is more than 22 weeks, usually we can continue the pregnancy with neoadjuvant chemotherapy, unless the cancer stage is very much severe. Okay. So these are the talk article charts. You can consider, you can try to read them if you want. Remember, after 14 weeks of 40 weeks of pregnancy, administration of several anti-cancer drugs is feasible including the platinum agents, which are most oftenly used for cervical cancer, like cisplatin or carboplatin. Okay. In the UK, usually after 16 weeks, these cervical cancer patients do get chemotherapy. Okay. And in the literature, they have mentioned that after 14 to 16 weeks, cancer therapies can be liberally used. Okay, in this those who don't know, please update this thing. It's not 20 weeks of gestation. In the UK and this talk article, they have given a 14 weeks, but in the FIGO guideline, it is given a 16 weeks. And also remember this, the next point is that the chemotherapy should not be given beyond 35 weeks of gestation. And it is very important to give a 3-week gap between 2 successive chemotherapies. Okay. So move on to the next question. Again, question from the cervical cancer is a hot topic. Look, cervical screening and cervical cancer, all of you had to need thoroughly. There is no escaping from this 2 chapters. Others? For cervical cancer, remember after 2018 guideline, there is no restriction of doing any investigation. Previously, the staging was kind of have restricted doing investigation. But now MRI is more liberally used to stage the cervical cancer. And in the pregnant woman, when it comes to the question of MRI, you should choose a non-contrast MRI rather than gadolinium enhanced MRI. And if it is a non-pregnant patient and the urea creatinine is normal, renal function is not compromised, you can go ahead with the gadolinium enhanced MRI as well. Is it clear, everyone?
Yes, sir.
Okay, thank you. Come on, next one. This is a very hot topic in UK and all over the Europe also. Is accessory uterine cavity mass or malformation? Accessory cavity uterine mass or malformation, very much hot topic in the UK, especially in the adolescent gynecology part. So many of pillars have been mixture of opinion, and many of you have, most of you may not many, most of you haven't choose the correct option. Remember in the question they have asked in MRI what features has always you will find in the vacuum. And read the options also carefully. Is it a central cavity without myometrial mantle or central cavity with myometrial mantle? Okay, let's see. Go into the details. Can anyone of you describe what is vacuum actually is? Is my voice is clear? Am I audible? Okay, that's very good. Yes, can you guys tell me what is vacuum? Accessory cavity uterine mass. A talk article and many papers have been published also in recent years. It has been, and the talk article has been, I think, 2020 or 2021. 2 years has been passed already. And already as question has been come from this topic. Although
Sir,
this wasn't the question. Yes, please anyone?
sir, yes, sir. It's basically congenital defect in which there is malformations, and along with there is a gubernaculum persistence.
Okay, just let me describe to you guys. Look at this picture. This picture I have taken from one of my own publication. It has been published in a FIGO International Journal. I have published many papers myself for vacuum also. And if you guys want, you can go and read this paper as well. But for you guys, for part 2 preparation, it's not required. In part 2 preparation, you guys need to read this guide talk article on the accessory uterine cavity. Look at this diagram carefully. This is a mass. This is the cavitated mass, which is cavity that's lined by endometrial lining and surrounded by a myometrial mantle. And it is always will be located just below the insertion of the round ligament. How does it get created? It's when the uterus develop from the mesonephric duct, a part of mesonephric duct get disattached, or there is a migrational defect which is more commonly caused. Due to the migrational defect, one portion get detached and it forms the accessory cavity uterine mass. When usually these patients, what happen is that, can you guys tell me which is the round ligament? What is the developmental part of round ligament? Anyone? Yes. So it is a basic gubernaculum. It's basically a dysfunction of gubernaculum due to develops. From the mesonephric duct, we know that the uterus do develop, and it is migrated through the gubernaculum. And this gubernaculum, when a portion of the mesonephric get disattached from this gubernaculum, it could not get incorporated into the developing uterus, and it stays just beside the gubernaculum, that is the latter part of round ligament, and it forms a mass. Now, usually it is very small and don't get detected at the birth, but when the period start, usually it has a cavity that is lined by endometrium, which is hormone sensitive. It starts when the period gets started. This is hormone sensitive. Endometrium also secrete a blood, and this fills with the blood and clots and get expanded and causes pain. And usually that's why during period, this patient comes with dysmenorrhea. Usually at adolescent age women, when severe dysmenorrhea are not managed with medication, ACUM should be suspected. Is it clear to everyone?
Yes, sir.
Okay. If you are having first time heard, it is a little bit difficult to grasp, but you should read this talk article or this paper. So how do you identify in the ultrasound or MRI? This has been a question. We just go into directly to the desk and see how it looks. Now I don't know how many of you do the transvaginal sonography or ultrasonography. What is this thing? Can anyone? What is this thing? My cursor is moving on.
Sir, it's a uterus and
Endometrium.
endometrial lining that
It's,
you are.
Endometrium.
it's an endometrium. And what is this? What is this thing?
Myometrium.
Yeah, very good. And you will be seeing at just like endometrium, when the what happens, you guys must have seen how the endometrium looks like a blackish during the period. It's kind of similar, but when you see this a small portion of endometrium or clot-like tissue, but outside this endometrial cavity, just lateral to the myometrial portion, then you should think of ACUM. And are you able to grasp it?
Yes, sir.
It should be lateral to the endometrial cavity, not with conjunction, and there should not be any communication or a connection between this myometrial portion, this endometrial portion, and this endometrial portion. They are separated by the myometrial tissue, and this cavity or the endometrial lining is surrounded by a myometrial mantle of tissue. You can recognize this myometrial mantle of tissue. It is similar to the homogeneous nature, and look at the texture of this myometrial tissue and this myometrial tissue. Both should be similar. Okay, in that case, you should consider it ACUM. If it is dissimilar or there is not only a central hollow, then it can be highly likely to be a fibroid. Okay, and it has similar type of vascularity when you do ultrasonography during the period or during when menstruation is occurring. It goes similar vascularity like in endometrium. See, the vascularity is reaching from the lining itself, it's surrounding the lining of endometrium. Okay. And whenever we're
Yes, sir.
doing an MRI, it's very important to do both T1 and T2, so T2 MRI as well. I hope you both of all of you know what is difference between T1 MRI and doing T2 MRI. In MRI, you will be looking as a circumscribed a mass with an endometrial lining, like similar echogenicity or similar looking tissue like an endometrial. We will be looking an endometrial like of nodule that is surrounded by a fibrous or similar to the myometrial like mass. And when you're doing a T2 imaging, the thinner lining of the cavity will appear as a hyper intense. And when you're doing a T1, it will be in the hypo intense. So it is very necessary to do both T1 and T2 like of imaging. See, both this endometrium and this endometrium, the endometrium of the ACUM is both of similar intensity in the T2 imaging. Okay. Are you able to grasp this thing? It's a very hot topic in UK. So, especially in adolescent gynecology, usually SBA comes from this topic in adolescent gynecology. Now, this has the recall question from this topic. I put the previous question because you need to know what is ACUM, but this was the actual question has come in the examination. Excellent. So all of you guys have to do right in the examination, I think. All of you guys are doing fantastic. It's a laparoscopy. Can you choose any of the other therapies in this case?
A is also an option, but C is more likely to cure it.
Yeah, it's very good. So you have read the article, I think. Yeah. So this is from the one of my own patient. Doing an accessory cavity surgical excision is mostly you can see how it's looking in the T2 imaging. This is the where just below the insertion of the round ligament, you will find this. I have bulged it with a vasopressin, then dissect it. And this is the exactly, look at the texture. It is similar to the fibroid itself, but it is outside the cavity and outside exterior to the normal uterine myometrium. Okay, and when we puncture it, you get this chocolate filled like color that is a clot collected blood due to the multiple times of degenerated material from this hormone sensitive endometrium which was lined inside. Okay, so let's move on to the next. You can go through this description, but does not require for much of you because most of the time they have asked only what is the management and the diagnostic portion they will ask. Waiting for the response. Actually, it's a very simple question. Please look at the parameters. Don't try to do, don't try to think very much difficult things at first. Many of you have chosen option E. Can you any of you tell me why the urine osmolarity? Can any of you unmute and tell me why you have chosen urine osmolarity?
To see any loss by urine, because all the parameters are low.
So what you are thinking of it? Clear MVP, that's correct. But what should be your immediate investigation? That is the question. That's why I'm telling you, don't try to make it complicate.
Sir, it's urine
Yes.
culture.
Yeah, of course. What will happen with if the potassium is very low? Of course, yes, low potassium cardiac arrhythmia can end up in a cardiac arrest. So the most immediate investigation they have are not the other investigation. Of course, you need to do urine osmolarity to look for the dehydration status and how we'll correct it, of course. But it's the immediate investigation of choice. Low potassium, of course, you need to do an ECG to rule out cardiac arrhythmia. Isn't it?
But what about all other parameters? It's all are low.
Yeah, but what will be the choice of appropriate immediate investigation they have framed it? Again, I am repeating, when you are choosing the option, please look at the question, what they have specifically asked for. Okay. So of course, these are the things. This has been from the talk article of the pregnancy in underweight women. It's very important, even if it is even if the patient was a normal BMI, normal weight, then even the answer would have been the same. Okay. So that's why I'm telling you, whenever reading the question, read it carefully and don't think of they are expecting you to answer very complicated things. They're asking for the simple things. Let's move on to the next question.
8% من البريجنانت women world have inadequate.
Sorry, I couldn't hear you. Are you saying anything? A recent guideline from the MRCOG has been published on this topic, and they have mentioned the importance of zinc in it. So most of you think that the answer should be they will reduce the preeclampsia. This question haven't come in the MRCOG detail. No, it won't reduce the risk of low birth weight. Few of you answered it correctly. It reduces the preterm birth. You guys need to read the strategy materials or talk articles. I think that will be helpful to answer this question. Okay. So just remember from this now, in the preterm guideline, they have also mentioned it. They recently, the MRCOG has published a guideline of the preterm delivery, also preterm and PROM. In that, they have also mentioned that the importance of the zinc intake in the pregnancy. Okay. So moving on to the next and our last question. Maternal medicine is a very difficult thing, but you guys need to practice it. And maternal medicine, if you guys are doing okay, so you guys are let you guys finish first. Excellent. So it is ultrasound. Almost everyone who has given the correct answer in this case. Remember, it's that the MRI without contrast should be used only in cases of uncertainty or when if you are considering the pancreas is necrotic pancreatitis. For the imaging, usually ultrasound gives you a good diagnosis, and only the first line investigation is required most often is the ultrasound. Only if the ultrasound is inappropriate or inconclusive or could not diagnose it, then only you should consider other investigation like CT or MRI. Okay. So if this patient has been other complications were there and they have mentioned it that the ultrasound could not diagnose it or it has been inconclusive, only then you should choose an MRI in this case. Otherwise, ultrasound is most often give around 80 to 90% time confirms the diagnosis even in the pregnancy. So just to give you a highlight of this important slide, delivery is not routinely indicated when the pancreatitis occurs and usually depends on the gestational age. If the gestational age is less than 34 weeks, usually we try to do conservative management. But delivery should be considered if there is a deterioration of the maternal condition and within 48 hours delivery should be done. And you can do either mode of delivery. It's not an indication of cesarean section. You can go for vaginal delivery as well, even in acute pancreatitis. So thank you everyone. I hope this 20 SBA give you some important lessons to understand how to practice your session and what things you need to consider it. Yes, of course, you guys are waiting for EMQ. I think I can have an EMQ session also in the coming week. So if you guys like it, please try to join our EMQ session as well. And we'll be doing an informative session as well. Thank you, everyone. Hope you guys have enjoyed it.
Thank you, sir.
Thank you. It's my pleasure. And don't worry regarding the exam. Go focus on your study and do just read and do the practice and do the revision. You will get it eventually. Everyone does it, remember.